I was reading it in one of the papers.
Okay.
They said if we're in the process, it's fine. It's
I think
fine.
everyone's back.
Okay.
All right, so 18. This chapter, even though the PowerPoint doesn't look that big, it's actually jam-packed with a lot of information. We're going to talk about everything from coronary heart disease to how atherosclerosis develops. We're going to talk about angina. We're also going to talk about different types of angina, different types of MIs, what happens with acute and chronic coronary syndrome. We're going to go how to diagnose an MI. We will be including laboratory values with this chapter, so just make sure you have your clinical records about handy. And we're also going to talk about 6 different types of heart murmurs. We're going to go over the different valvular disorders that can occur and even infections of the heart. So, for those of you who like cardiac, you'll like this particular chapter. Okay, so 18 alterations in cardiac function. With this one, the first topic we're going to discuss is coronary heart disease. Okay, coronary heart disease. When you hear the term coronary heart disease, it is associated with coronary artery disease because what happens, it is the coronary artery that we know supplies blood normally to the heart muscle tissue, okay, to allow it to function. So what happens here, if there's an insufficient amount of blood, oxygenated blood getting to the myocardium, this will cause this particular issue. And it's usually due to an atherosclerotic plaque. So we know from week 1 when I discussed with you guys how atherosclerosis develops, it can develop inside the vessel wall. Okay, and so what will happen here when atherosclerotic plaque develops inside the vessel, obviously that will diminish the lumen size, which will diminish the blood flow getting through. Okay, so what can happen if a person has atherosclerosis or atherosclerotic plaque in a coronary artery? We don't want to jump and say, oh, they're going to have a heart attack immediately. It could possibly happen, but there's other things that can happen other than just a heart attack. Okay? So the first thing that they have here as far as the sequela is going to be angina pectoris. Angina pectoris is a term for chest pain. That's just a clinical term for chest pain. And so why is this individual getting chest pain? They're getting chest pain because there is a lack of blood flow getting to that myocardium, okay? Just the lack of blood flow getting to the myocardium to the point that the cells are going under the anaerobic metabolism, leading them into that pain, okay, that type of angina. Now, what is the definition of a myocardial infarction? The definition of this is when you have the heart muscle tissue that dies. So this is when heart muscle tissue dies. So this is when an individual has diminished blood flow in the vessel, or let's say the coronary vessel, to the point that there's a lack of blood flow getting to the heart muscle tissue to the point that the tissue dies. Once the tissue dies, that is considered the infarction. Okay, once the tissue dies, that's the infarction. You want me to go over it?
Yeah.
Once the tissue dies, that's the infarction. So say, for example,
I'm just trying to remember. Once the tissue dies, doesn't it turn into not connective, but
it'll get fibrotic.
the fibrotic?
Yes,
Right?
it'll get fibrotic.
So every time you have a heart attack, it's like
Every time you have a heart attack, that tissue is fibrotic.
Right.
And meaning that now that muscle tissue is definitely in a compromised situation. So, don't laugh at my heart, I don't know how to draw it any other way. I don't know how to draw an anatomical heart, so that's all I know. Okay, so let's say for example this person has a plaque. Okay, let's say it's a really big plaque. What's going to happen is they are going to, in their coronary vessel, just maybe have a little trickle of blood. Okay, and sometimes in some cases there's no blood in that vessel that's flowing to the heart. So if there's no blood flowing to that area of the heart, that heart muscle tissue is going to die because it's not getting enough, it's not getting any blood. Once it dies, that's considered an infarction. But as long as you still have blood getting to the heart muscle, even if it's diminished, even if you still have a little blood getting through, that will not cause an infarction. That'll just cause like an angina. But as soon as you have muscle tissue death, once tissue death occurs, that's the infarction. Okay, so dysrhythmias. Dysrhythmias, if we have a situation where there is diminished blood flow to the heart muscle tissue, is it going to contract normally as it would? No. So what's going to happen, the actual rhythm of the heart's contraction is going to be off, which will lead to the title of what we call the dysrhythmia. Okay, so there's going to be difficulty in the rhythm of the heart, difficulty in the heart's contraction. Also, this situation of decreased blood can lead to heart failure. Okay, and we'll talk about that in more detail at 19. And then sudden cardiac death. Okay, if it gets to that point. Now, what are some known risk factors that we know for coronary heart disease? And usually they say the main culprit of coronary heart disease, again, is atherosclerosis. So we talked about some of these risk factors week 1. So what are some risk factors that a person could have that can lead them into atherosclerosis? Diet, very good, exercise, and diet in particular is saturated fats. Okay, and that needs to be a stress to the patient because they may not know, okay, what to do. So diets high in saturated fats, so they need to decrease that, stop eating all the fast food and that type of stuff. Diet, as you said, exercise, so keep in mind that obesity is also a risk factor. Age sometimes can be a risk factor. Sex, so they do say males tend to be more common. And smoking, definitely. Smoking, I believe good about that, yes. Smoking is definitely a risk factor. Okay. So yes, all of these things can possibly lead to atherosclerosis. Now, when atherosclerosis occurs, as I showed you in that picture here, so this will lead to obviously a narrowing in the lumen of the vessel. So if you have a big atherosclerotic plaque sitting there, obviously that's taking up space. Okay. So when that takes up space in the lumen, this could lead to cardiac ischemia, which we know ischemia, the term lack of blood flow getting to those tissues. So this is because of that thrombus formation that's in the vessel. Also, the vessel, believe it or not, undergoes something called a vasospasm. So remember how I explained to you how the body will respond when you touch a hot stove or even when you have an injury and it closes in? Same thing here. If it recognizes that something's lingering around that's kind of foreign, okay, inside the vessel that should be there in excess, the vessel's not just going to dilate and allow it to happen. It's actually going to constrict. So it will go into a little coronary spasm. And so with that on top of the thrombus formation, that actually makes it more compromised. And then endothelial cell dysfunction. If we have lipids flowing through the cell, I should say not the cell, but flowing through the vessel, is that going to cause the endothelium to be disrupted? Yes. Okay, so keep in mind, lipids, they do have an irregular shape, like I explained that whole thing the first week, and they can cause a disruption to the endothelium. Now, the next thing we're going to take a look at is understanding lipids. And so this is where we're going to add in a lipid panel on our clinical reference guide, but I want to go over the molecules with you guys first, okay? So you guys may have touched on this maybe in physiology, but I'll review, I'll go over just chylomicrons and LDLs and HDLs with you. So, chylomicrons, if you look at this particular molecule, and just to let you know, you don't have to memorize the percentages, but I just want to go over them with you so you'll understand what's going on. So chylomicrons, these are very large molecules, as you can see. They are made up of 85% triglyceride and 5% cholesterol. So kind of like our free triglycerides that are kind of floating. These are normally present in your bloodstream after you eat a meal. So it's normal to see this in the bloodstream after you eat a meal. However, if a patient is having fasting blood work done, should this be in the bloodstream? No. And if it is, that means that they weren't compliant and they ate something. So you'll always know if that person had something to eat, okay, and did not fast when they were supposed to. Now, the next set here that we have are considered our lipoproteins. I think you guys remember from physiology that lipoproteins, these are used to carry lipids through the bloodstream so they can go to various places and do what they need to do. So we're going to go over in detail LDLs and HDLs. Now VLDLs, I want you to know that this particular lipoprotein, it is considered like the bad one and the same, almost in line with LDLs. Although when you look at a lipid panel, sometimes on blood results, they may have it, sometimes they may not, but it kind of falls along the lines of LDL, but they mainly look at the LDL levels. IDL, I'm not even sure if they usually have this on the panel, but IDLs are what we call intermediate, and so not really much to say about that, but usually they look at the VLDLs and LDLs. Now, LDLs in particular, these are our low-density lipoproteins, and I think we all know, and they do consider this our bad cholesterol, okay, the LDLs. Now, why are the LDLs bad? They're bad for a couple of reasons. So one reason, when you look at the composition, it's 55% cholesterol, 5% triglycerides. So a good 60% of it is like fatty. And then 20% of it is protein. Another reason why LDLs are bad is because of how they behave. LDLs actually will take lipids, if you want to jot this down, it will take lipids through the bloodstream and take it to the surface of tissues. So LDLs will take lipids through the bloodstream and take it to the surface of tissues. Now, if you have lipids sitting at a surface of a tissue, is that a good thing? No. Okay, we would never want lipids just sitting there. And what do you think is the body's response if we just have lipids sitting on the surface? What do you think the body's going to do to react to that? It's going to attack it. Very good. So keep in mind that the immune system will attack it. This will undergo the inflammatory process. And just imagine if that continues over and over and over and over again, what you're going to have now is organ damage eventually. Okay, and so this is the reason why we don't want high LDLs, because it can lead to eventually organ damage. Yes?
Would that be the same thing as fat?
Yes, so what will happen is the LDLs, they say, are the carrier proteins for the cholesterol, that carry the cholesterol. Then you have your regular cholesterol levels that just are floating in the bloodstream. But these are kind of like the carriers for it. So they don't want high LDLs because of the way they behave. Okay, because they're going to take that cholesterol, the lipid, all that fatty stuff, and take it to the surface of tissues. And it'll just sit there at the organ. And not only, I don't want you to think of it as, okay, we're just having a fatty organ, fat sitting around an organ, but the main picture is that the body will continuously try to attack it, which means that if it continuously undergoes inflammation, that's going to lead to organ damage. Okay, HDLs. HDLs are considered our good cholesterol, okay? And with HDLs, what's good about it, if you look at the composition, 50% protein, 20% cholesterol, 5% triglycerides. Okay. Another thing that makes this good is the way it behaves. It does something different than the LDLs. HDLs actually takes that cholesterol to the liver so the liver can break it down and get rid of it, which is what we want. So HDLs take that cholesterol through the bloodstream, take it to the liver so the liver can break it down, which is good. We want to get rid of that cholesterol, get it out, okay, out of our system. Now, you guys may know this. What is the best way to raise HDL levels? Does anyone know the best way to raise HDL levels? Exercise. They say exercise is the best way to raise HDL levels, in conjunction with obviously changing the diet. So you don't want to just eat a whole bunch of garbage and exercise and think that that's enough. But yes, you should change your diet, but they say exercise is the best way to raise it. Okay, now if you guys can pull out your clinical reference guide, I believe it's on page 488 in that guide. At the bottom, there is a section called Lipid Panel. There's a section called Lipid Panel. So we're now going to include this, okay, into our So I do need you guys to know this for the next week's test. I don't have it. So, let's just go over this. So the first one they have there is cholesterol. So just highlight cholesterol and just know those levels. And I only need you to know the desirable amount, I'm sorry. I only need you to know the desirable amount. I don't need you to know the high risk, very high risk, okay? I'm not gonna have any questions tailored around that, so just the normal one. The next one you should have there is HDLs. HDLs, they do have a different value for men and women. I do need you to know that as well, for both men and women. Women, we need a little more HDLs. Why? We have a little more areas where we distribute fat. We need a little more HDLs than men. Men have more muscle mass, so they distribute fat differently. LDLs. LDLs, again, I just need you to know the normal range, which I believe is, what is that, less than 130? Okay, so just less than 130. And then the very last one, triglycerides. Okay, so we'll incorporate that. Test and let you.
No.
So moving on. We already discussed this. Lipids are, yes, transported as lipoproteins, which we know. Lipoproteins, or LDLs in particular, this LDL, are associated with a greater risk for atherosclerosis. So when we do see high LDLs, that's kind of a trigger, okay, that can lead to possible atherosclerosis, as well as I was explaining to you, organ damage overall, okay. And HDLs we know are good because they take that cholesterol to the liver so the liver can break it out, break it down and release it. Okay, so I'm gonna make your life a little easier. And slides 7 through 9, I want you guys to watch this YouTube video called Atherosclerosis. So remember week 1 when I went over the example of how the atherosclerotic plaque forms in the vessel and I went through the whole thing, the lipids coming, macrophages and so forth. So slide 7 through 10 actually breaks that whole process down. So just to save time so I don't have to review it all over again, there is a YouTube video called Atherosclerosis by a company called Nucleus Medical Media. And they do a really good job with the visual. It's an animation that shows you how this plaque forms in the vessel. So again, I explained it to you guys before, but it gives a really nice visual. Those of you who are visual learners and like videos and pictures and images, this company, Nucleus Medical Media, they have really good videos. They have videos pretty much for every kind of disorder that's out, most common disorders. So most of their videos are on YouTube. They're kind of like a sample version, so you'll see like a sample across of it, going across the screen. But I do want to ask Dr. Lerner at some point if we have it in our budget to order the videos from the company. I heard they're very expensive, but to maybe order those videos and incorporate it on Blackboard, I think would be nice because they are really good animations. Okay, so slide 7 through 10 is all kind of described in that video. Okay, so we can save some time with that. Slide 7 through 10 is in that video. Okay. Pathophysiology of ischemia. Ischemia, we already know what this means. Ischemia is definitely a lack of oxygenated supply or oxygen supply getting to the tissues to where the tissues can't function or meet their metabolic demands. Okay, so if they don't have enough oxygen, they can't do their job. There are some critical factors that are important to make sure that we have enough oxygen supply getting through the vessel. Number one is something called the rate of coronary perfusion. When you see the term perfusion, and if I did, make a medical term list, perfusion would be on there. Perfusion is a term for the rate of blood flow. This is a term for the rate of blood flow. Perfusion means the rate of blood flow. And so what we want to know here is, what is the rate of coronary blood flow? So what is the rate of coronary blood flow? Now, also myocardial workload. Myocardial workload meaning, is the heart contracting? Is it working? Is it contracting and pushing the adequate amount of blood that we need for circulation? That's important. So we need to know, is the myocardium in its normal workload. Now, for coronary perfusion, it can be altered by, number one, we already discussed the atherosclerotic plaque. So we know if a plaque is sitting there, that's going to alter perfusion or the rate of flow. If we have too many platelets, as we just discussed in the last chapter, platelet aggregation or thrombocytosis. If you have too many platelets, this can also make a clot formation. Vasospasm, which we just discussed, and also failure of autoregulation by microcirculation. So let me go over this. So, do you guys remember microcirculation? Kind of. Please don't forget microcirculation. If you know this, this will help you answer a lot of questions. Okay, just understanding what's happening with microcirculation in the flow of blood. Okay. So, just to go over this really quickly. Artery, I usually call it AOA. Arteries, we know, take blood away from the heart. Arterioles are smaller arteries, and they also have a special function, which I'll come back to. Capillaries, we know, are there for exchange. So anything that needs to get exchanged, whether it's gas, nutrients, waste, whatever it is that needs to cross over, crosses over here. Venules, we know, are smaller veins, and veins bring blood back to the heart. And remember, they do have valves, so they don't go back this way. Now, arterioles. This is kind of our star vessel in microcirculation. And if you remember, arterioles have a special function, and they call them variable. And the reason why they call them variable is because arterioles, if you remember, they can constrict and dilate, constrict and dilate. Now, this is how it works. In an artery, we know that blood is at a very high velocity, okay, which is why you would never want to do a venipuncture, okay, in an artery, because blood is at such a high velocity. And if you look at those gory movies and they sever arteries and blood spurting out all over the place, okay, that's showing the velocity of blood, okay, in the artery. It's very, very high. Now, that high velocity of blood obviously needs to slow down so we can get through the rest of circulation. If it doesn't slow down, if it were to just continue to be high, we will always walk around hypertensive forever and ever, okay? And then the other thing too is we would never have proper diffusion taking place if that velocity of blood doesn't slow down, because it'll just go too fast through circulation. Now, what makes it slow down are the arterioles. Arterioles are so important when we talk about how they regulate blood pressure and how they regulate the flow of blood in circulation. Please make sure you know that. That is so important to know, even when we talk about hypertension, okay, or normal blood pressure in the body. Arterioles are the ones that set the tone for pressure. They set the tone for pressure, and they set the tone and pace for circulation. Because when we have this blood in an artery, high velocity, arterioles, when they get that blood, they're going to contract, constrict, dilate to the point that it will slow down that blood. So now when it gets to the capillaries, venules, veins, it'll slow down. Okay, so we should be good to go. All right, now, the whole point of saying that is if you have a failure of microcirculation doing what it's supposed to do, this could also cause an issue with circulation and lack of ischemia. Okay. Poor perfusion pressure, so again, if we don't have the proper pressure that's taking place, that can also cause ischemia as well. Now, get to the fun part. So the first disorder that we're going to talk about are coronary syndromes. So we're going to break it down into acute and coronary syndromes. So coronary syndrome, when we talk about chronic diseases, we know have a slow progression. So this is going to be a situation where a person slowly develops an atherosclerotic plaque that leads to them having a coronary syndrome. Okay. So let's say, for example, we have someone that is overweight, smoking, okay, poor diet, they're eating McDonald's, Krispy Kreme, and all that, okay, type of foods. And what's happening is, as they continue to eat those types of foods, obviously that'll lead them into an atherosclerotic state. This individual will develop this plaque over time. So say, for example, it takes maybe 4 or 5 years to develop this plaque. This plaque is in the vessel wall and it's stationary. It's a stationary plaque, but because it's in the vessel wall, it is now diminishing blood flow to the myocardium. This person is having an angina, but they're not having a heart attack. They're having an angina just because it's a stable plaque, just enough to diminish blood flow. Okay. So the type of angina that they're having is what is called a stable angina. And I'll explain the difference between stable and unstable in the next 2 slides. But they're having what is called a stable angina. Now, another thing that it can occur, and even though this word looks fancy, but it's not. Ischemic cardiomyopathy. Ischemic, we know, is a lack of blood, okay, oxygenated blood, and to the heart myo muscle. That's all that's saying. Like the oxygenated blood to the cardiac muscle. Now, acute coronary syndrome. So let's say, for example, that same person with the plaque that they already have, let's say he keeps enjoying himself, and going in and out, and famous days, and all that fatty stuff, okay, and completely enjoying himself with all this food. Now, what's going to happen as he continues to enjoy himself with this food, he's going to put himself at a further atherosclerotic state, which means that he may add now to this plaque. So now this plaque could possibly form or change form, and it can actually get bigger. Maybe it can get bigger, or maybe it can even change in shape and maybe break off. So as long as this person has acute changes to that plaque, now that puts them in an acute syndrome. So it takes them out of the coronary to an acute. So once they're in an acute syndrome, the signs or symptoms are actually going to be a little more severe. Okay. So once they're in an acute syndrome state, they will now have what is called an unstable angina. An unstable angina is definitely worse than a stable, and I'll go over that in a second. Or, and I don't want to say and, or it could lead them into a myocardial infarction. And we already know an infarction is only if they have tissue death. Okay. So even though they're in an acute coronary syndrome, they may be there without the tissue death or with it. It just depends. And we're going to go over how you diagnose that in a little bit. Okay, so chest pain, when we talk about these types of anginas, they are intermittent type of chest pain. However, the intensities are different. Okay, we're going to go over the intensities in a little bit. Now, another thing I want to point out, which is the second sentence here. When a patient has cardiac issues, what is the next immediate organ that could also be affected? Lungs. Very good, the lungs. Understand, and sometimes you will hear definitely the term cardiopulmonary diseases or disorders. Why? Because if the heart itself is not functioning, what is the next immediate thing that the heart is actually supplying blood to? Not only the rest of the body, but the lungs. And so if right-sided circulation is off, the lungs will definitely be affected. And so sometimes you can also check for certain signs and symptoms in your patient that are cardiac related with the lungs. Okay, so sometimes you may listen for fluid in the lungs. Patients may have pulmonary congestion, shortness of breath. Why? Because the right-sided circulation is thrown off till the lungs cannot function as they should. Okay, so let's get into the different types of angina. So stable angina or typical angina. And I'll give you another name. Sometimes they also call it classic angina. Okay, so I guess depends on what you're looking at. Sometimes they also call it classic, so there's like 3 different names. Now, this type of angina, if I can explain like using a pain scale of like 0 to 10, the pain on an intensity level, let's say it stays around a 4 or 5. Okay, for example, let's just say it stays around a 4 or 5. Meaning that the intensity just kind of stays around that area. Not to say that it doesn't hurt, it's still painful, but the intensity stays around a consistency. Okay. If we're talking about an unstable angina, the intensity is different. The intensity actually gets higher. So it'll go from 4, 5, 6, 7, 8, it'll just get worse, okay, over a period of time. Now the next angina that they have listed here is presmetal, also known as variant angina. They call this unpredictable attacks of angina. This is titled Unpredictable Attacks of Angina. So I'll give you an example. Have you guys ever had like a sharp pain on your side and it's grabbing and you're like, oh, and then it hurts for like a few seconds and then it lets up and then you never feel it again? That's an example of presmetal angina. Okay, so I don't want to scare you that that's what you had, but they do say that this is one of the most dangerous types. Why? Because sometimes when patients have this, they may not think that that's what's going on, and they think it's like maybe just a cramp or muscle in the pull or whatever like that. However, they do say that this type of angina develops when an atherosclerotic plaque is developing. So they do say that this occurs when an atherosclerotic plaque is developing. And then when we talk about unstable or crescendo angina, as I explained to you with the intensity already, it gets worse, okay, intensity. However, I just want to make a distinction. Sometimes patients, again, can have an unstable angina that has nothing to do with an infarction. And then they can have an unstable angina that has to do with the infarction, okay? So if a patient is having an infarction, an MI, just to go over some signs and symptoms, you guys may know this. When a patient's having a heart attack, not only are they having chest pain, but the chest pain feels like what? Do you guys know how they describe it, the description of the chest pain?
It's like an elephant sitting.
Very good. So the classic sign, they say it feels like an elephant sitting on the chest, like a really hard, crushing sensation. Even sometimes a choking sensation, okay, because of the pressure. Also, the pain can radiate, I think we know, to the arm, as well as the neck and the jaw area. And sometimes to the back, okay, so it can kind of radiate all along the trunk. Another thing with heart attacks, if a patient's having a heart attack, keep in mind everyone can't tell you, okay, that I'm having pain here. Understand that there's other signs and symptoms such as paleness,